The following podcast is part of a certified educational activity titled Polishing Management Protocols in HER2-Expressing GI Cancers with Targeted Agents, a focus on refining team-based strategies to individualize BTC and GEA care. Access the entire activity and complete the post-test at peerview.com/NXP860. Downloadable slides and practice aids are also available.
Good evening and welcome to tonight's program entitled Polishing Management Protocols in HER2-Expressing GI Cancers with Targeted Agents. Tonight panelists are Dr. Jeffrey Koo, MD, and Shubham Pant. I'm Elena Lamova. So in terms of our goals for today, we would like to recognize current evidence supporting molecular testing and its role in treatment selection for patients with HER2-positive GI cancers. We're going to discuss personalized treatment strategies based on molecular findings, the current evidence, and patient-specific factors when managing HER2-expressing GI cancers. And then we're going to apply practical strategies to manage and mitigate treatment-related AEs associated with HER2-targeted agents, in particular when managing BTC and gastroesophageal cancers. As I've mentioned, I'm Elena Lamova. I'm an assistant professor at University of Toronto at Princess Margaret Hospital. So we all know that HER2 aberrations are an established therapeutic target in breast and GI cancers. But what we have recently found out is that HER2 aberrations are also present across a variety of other solid tumors. So these would include lung, salivary gland, biliary tract, pancreas as examples. A number of novel HER2-targeted therapies are being evaluated in GI cancers, which indicates that there is a role and impact of these therapies, which will likely continue to expand, along with a need for broader HER2 testing. When we look at the management of advanced biliary tract cancers and the current shortcomings, a recent assessment of over 1,000 oncology providers who treat cholangiocarcinomas found that 81 were not confident in their ability to use targeted therapies in patients with advanced cholangiocarcinoma. When we look at who receives what in these tumors, 85% of patients will receive gemcitabine-based chemotherapy as first line. Only 50% of these patients then go on to initiate second-line treatments, which would mainly consist of 5-FU-based therapies. And very few patients will actually receive third-line treatments. The median duration on any of these treatments is extremely short. In HER2-positive gastroesophageal adenocarcinomas, looking at real-world evidence, we find that 1/3 or 34% of patients are not tested for HER2 status when we look at electronic health record data from 2011 to 2018. 25% of all patients do not receive treatment after diagnosis, and only 58% of patients who are HER2 positive receive HER2-targeted systemic therapies in the first line. Of the patients who do receive treatment, only half will go on to second-line therapy and less than 1/5 will receive third-line therapy. And when we look at giving these patients second-line targeted therapy, it's often delayed from the time of progression, particularly in community oncology practices. So is there an unmet need in HER2-positive GI cancers, and can this be addressed? This question was looked at using the Netherlands Cancer Registry and the Dutch Pathology Registry, and they looked at over 3,000 patients. What they were able to show is that HER2 testing has increased over time. So overall, 77% of HER2-positive patients actually go on to receive trastuzumab. The median overall survival was higher in patients with both positive and negative HER2 status. And when you looked at patients who were not tested, their outcomes were the worst. So actually understanding the appropriate biomarkers is important in all patients. There are various mechanisms of action of targeted and ways to target HER2. So there's the single epitope monoclonal antibodies, which would include pertuzumab, trastuzumab, margetuximab, which work by inhibiting receptor dimerization, promotion of receptor internalization, and engagement of ADCC. There are ADCs, for example, trastuzumab deruxtecan, and they work by targeting delivery of highly cytotoxic agents directly into the tumor cells. Then we have small molecule inhibitors of the TKIs, so lapatinib, neratinib, tucatinib being one of the newer ones. And finally, we have bispecific antibodies. For instance, Zanidatamab, and Zanidatamab in particular targets the trastuzumab and pertuzumab binding domains. So our first speaker tonight is Shubham Pant. He is a professor in the Department of GI Medical Oncology and Department of Investigational Cancer Therapeutics at University of Texas MD Anderson Cancer Center in Houston, Texas.
Well, thank you so much, Elena, and good morning, good evening, and good afternoon to our viewers. I'm going to talk a little bit about individualizing BTC management for biliary tract cancer with HER2 targeted agent. And we're really going to discuss how a personalized approach can improve outcomes. So as we know, biliary tract cancers is a heterogeneous, disease. It's basically divided into three parts: gallbladder cancer, intrahepatic cholangiocarcinoma, and extrahepatic cholangiocarcinoma. And that is important because the HER2 positivity or overamplification can be different in these different subsets. So about 20 to 30% of gallbladder cancers can have an overexpression of HER2, about 10 to 20% of extrahepatic cholangiocarcinomas, and about 1 to 5% of intrahepatic cholangiocarcinomas. So it's very varied according to the different subtypes. This is the NCCN guidelines for metastatic cholangiocarcinoma. As you can see on the right, for HER2 positive tumors, trastuzumab and pertuzumab have made it into the NCCN guidelines on the basis of my pathway trial that I'm going to talk about. So this is precision oncology, and it's really hit home for cholangiocarcinomas. About a decade back, or even half a decade back, there were not many options, only chemotherapy options for these patients. However, now we sequence most of these cancers, at least in the metastatic setting. And as you can see, there have been different approvals like pembrolizumab for MSI high tumors, larotrectinib and entrectinib for NTRK fusions. And the big ones, which is a higher percentage, is pemigatinib, which is an FGFR inhibitor for FGFR2 positive cholangiocarcinoma. Then we had infigratinib, also received accelerated approval. Ivosidenib was for IDH1 mutations, and futibatinib is the most recent new kid on the block, which got FDA approval for FGFR2 positive cholangiocarcinoma. And one drug that we're going to talk about today, Zanidatamab, which got the breakthrough therapy designation for HER2 amplified cholangiocarcinoma. And like we talked about, there are different genomic differences based on tumor location, and this is just a cartoon of the same. So the main thing to remember is that FGFR and IDH1 are mostly in intrahepatic cholangiocarcinomas, about 5 to 10% of these patients. However, HER2 positivity is more in extrahepatic cholangiocarcinoma and mostly highly expressed in gallbladder cancer. And there are all these other, obviously, targets. So it's a very target-rich disease. So we really should be doing next generation sequencing on all our patients with advanced disease. This is just showing you the different ways of detecting HER2 amplification. As you can look on the left is immunohistochemistry, then fluorescent in situ hybridization, and next generation sequencing that we use very commonly now. And this is the different ways, the comparison between the detection method for HER2 overexpression and amplification. What we can get from this is that if you do a next-gen sequencing, it does enable the assessment of HER2 copy number and mutation simultaneously, along with FGFR, IDH1, MSI high, so it can add tumor mutational burden. So really, this can point in one test, it can give you different targets for any potential targeted therapy options for our patients with advanced cholangiocarcinomas. And I'm going to talk a little bit about chemotherapy in this disease, and unfortunately, it doesn't do a lot. So as you can see, this was the ABC06 trial, and the response rate for the chemotherapy was 5%, with a median progression-free survival of 4 months. And this was in the second-line setting, so after first-line therapy for advanced disease. So remember that number, 5%. This was a small retrospective look in about 100 patients, which was resected patients with cholangiocarcinoma, patients who were HER2 positive, very much like breast cancer. They did very poorly compared to the patients who did not express HER2. And this tells you that this HER2 is a true oncogenic driver in this disease. And this is another kind of retrospective analysis done by one of my colleagues, Dr. Dumbrava. And what she looked at was ERB2 or HER2 amplification by NGS beyond conventional indications, and which are breast cancer and gastroesophageal cancer. So this was for all patients other than that. About 4.9% of the patients were biliary tract cancers. And what it showed was that if the patients in these malignancies were HER2 positive and they got a HER2-directed therapy, then they did better than those patients who were HER2 positive and did not get a HER2-directed therapy. So again, it tells you that this is a true driver, oncogenic driver in this disease. This was the My Pathway trial that we talked about. Again, this was part of a basket trial. So majority of what we know in biliary tract cancers, other than a trial that I'm going to discuss today, is part of a basket trial. So in this, 661 patients were enrolled on My Pathway, and 39 with HER2 positive metastatic biliary tract cancers. Importantly, they also included ampullary cancers in this that have not been included mostly in other trials. The median previous lines of therapy was 2. Gemcitabine-based regimens were the most common regimens given previously. And as we can see, the overall response rate was 29%, with a progression-free survival of 4 months and overall survival of 10.9 months. We're going to talk about the HERB trial, which was presented last year at ASCO. Again, this was a smaller trial, an investigator-initiated trial of this trastuzumab deruxtecan in patients with HER2 overexpressing biliary tract cancers. And as you can see, it has this is a classic ADC, has a target, has a linker, and then has the payload, which is a topoisomerase inhibitor. This was done in Japan. They enrolled 30 patients with histologically confirmed unresectable recurrent BTC. They did have centrally confirmed HER2 expressing status. It is important to note that 50% were gallbladder cancers that we would expect in these patients. And about 10 patients were IHC 3+, and about 12 patients in the HER2 positive, which was designated HER2 positive, were IHC 2+. So 22 patients in all were HER2 positive for this trial. And the response rates for these patients was 36.4%, and the duration of response was 7.4 months for the patient who responded. And as you can see on the right side, you can see the waterfall plot and the spider plot. And this is more data of the same trial. As you can see, the median progression-free survival, and I'm just focusing on the HER2 positive patients, was about 5.1 months with a median overall survival of 7.1 months. For HER2 negative, it was understandably less, a median progression-free survival of 3.5 months and a median overall survival of 8.9 months. And again, this is not a benign drug by any stretch of the imagination. It almost behaves in a way like chemotherapy. If you can see, there was 68.8% of the patients got any grade of anemia, and about 53% did get grade 3 or higher. About 31% had grade 3 or higher neutropenia, and about 31% grade 3 or higher white blood cell count decrease. And importantly, there was a lymphocyte decrease also. And the most important toxicity, or one of the very important toxicities that we have to look out for, is the interstitial pneumonitis, which was grade 3 or higher in 12.5% of cases. So really have to know how to treat these patients and catch these, especially these pneumonitis cases early in the disease, in the treatment. Now I'm going to talk about Zanidatamab. It's a bispecific antibody for HER2 expressing tumors. As was said earlier, it binds to two domains on the HER2 protein, the extracellular domain 2 and extracellular domain 4, similar to the binding of trastuzumab, which is on ECD4, and pertuzumab, which is on ECD2. Now, this dual HER2 binding of zanidatamab drives a unique mechanism of action. It gets enhanced receptor clustering on cell surface compared to the trastuzumab pertuzumab, and there's inhibition of cellular proliferation, and then other cytotoxicities like ADCC and CDC-driven cytotoxicity. And this was part of a basket trial, which was again, just different baskets for HER2-expressing metastatic cancers. And as you can see at the bottom, we had 22 patients in this basket trial for BTC, and this was recently reported in the Lancet Oncology. Again, this is a very busy slide, but the main thing you have to remember from this is that about 23% or 1/5 of the patients with BTC did get prior HER2 targeted therapy, and the patients all got trastuzumab in this setting. The main side effects of zanidatamab is diarrhea, infusion reactions, mostly the grade 1 and 2 with a few grade 3 and 4 events. And this was the waterfall plot of all the patients. There was an overall response rate. So responses or at least benefit across all tumor subtypes, which was about 37% was the overall response rate in these patients. And this was the activity with, especially with in biliary tract cancer patients. The overall response rate was 38% with a median duration of response of 8.5 months. And this kind of interesting and exciting phase 1 data led to this global phase 2b study of zanidatamab monotherapy in HER2 amplified BTC. This is a truly global trial. It was originally it had to enroll about 100 patients. We ended up enrolling 80 patients to the HER2 positive arm, defined as HER2 2+ and 3+, and about 7 patients to the HER2 negative arm, which was 0 and 1+. But zanidatamab was given a 20 milligram per kilogram IV, given once every 2 weeks. We imaged patients every 8 weeks with the primary endpoint of objective response rate and the key secondary endpoints of duration of response, disease control rate, and progression-free survival, and the adverse events. Again, this was a global trial, the first of its kind. Majority of the trials before were done as smaller parts of a basket trial or investigator-initiated trial in certain geographic locations. Truly global trial. It was 32 sites, 9 countries across 4 continents. And this was the confirmed overall response rate was by independent central review and by investigator assessment. Interestingly, it was exactly the same, 41.3%. 1 patient had a CR, and I'm now focusing on the independent central review. 32 patients had a PR, 22 patients had stable disease for a disease control rate of 68.8%. And the clinical benefit rate defined as CR, PR, and stable disease greater than or equal to 6 months was 47.5%. At the time of data cutoff, 16 patients had ongoing responses. This is the spider plot of the same. Those little green arrows that you can see were the 16 patients who had ongoing responses. So again, like we said, 41% of the patients had a confirmed overall response rate. And the patients who were responding, the duration of response was a durable 12.9 months. And interestingly, the time to first response was a relatively short 1.8 months. Remember, we were scanning these patients every 2 months or every 8 weeks, actually. This was the progression-free survival was 5.5 months in our cohort. And remember, I'm talking about only HER2 positive or over our amplified cohort, which was IHC 2+ and 3+. And these patients were ISH or in situ hybridization positive. So IHC 2+, 3+, ISH positive. The overall survival data is not yet mature. And these were the adverse events of special interest. The adverse events really were similar to our phase 1 trial. So diarrhea and infusion-related reactions were the most common ones, but these were the more of the adverse events of special interest. The infusion-related reactions, again, majority grade 1 and 2. All the events resolved, and generally within 1 day, Most of these events did occur during the first cycle of treatments, and most had really no recurrence. We did see decreased LVEF in 5 patients, clinically asymptomatic, and the events were confounded by pre-existing or concurrent conditions. Diarrhea, again, about 43.7% any grade, about 6.9% greater than equal to grade 3. All but 2 events managed outpatient, like we do for these patients with loperamide. And most patients really resolved at the time of data cutoff, with a median time to resolution of about 2 days. No patients really discontinued treatment due to treatment-related adverse events in this trial. So to conclude, Zanidatamab demonstrated anti-tumor activity, including a rapid and durable responses in patients with treatment-refractory HER2-positive BTC. Zanidatamab demonstrated a manageable and tolerable safety profile. There were few events which lead to treatment discontinuation. We did not see any grade 4 AEs, and no deaths were treatment-related. The most common AEs were infusion-related reactions. Interestingly, we did pre-medicate a majority, almost all the patients were pre-medicated in this trial for the infusion-related reactions, and diarrhea, which was predominantly low-grade and reversible. And these results do support Zanidatamab having a meaningful clinical benefit and potential as a future treatment options in patients with HER2-positive BTC. We also have additional studies which are both planned and active, including Zanidatamab in combination with cisplatin and gemcitabine. Now, looking ahead, this ASCO was actually very exciting for HER2-targeted BTC, which is actually a very niche patient population. So we were excited about multiple abstracts, including the Zanidatamab data, which was presented at ASCO. There was also presentation of the tucatinib and the trastuzumab data. Again, this was part of a phase 2 basket trial. There were about 30 patients in this trial, so a smaller subset. The confirmed overall response rate was 46.7%. The median duration of response for the responders was 6 months, and the median progression-free survival was 5.5 months. We also saw the Destiny Pan-Tumor02 interim analysis, which was for TDX, which was a broad activity for HER2-expressing solid tumors. Again, there were 22 BTC patients in this. The overall response rate was 37.1%. For IHC2+ was a little bit less, about 27.2%. And for overall response rate for IHC3+ was about 61%. We also saw a smaller, very interesting trial. It wasn't smaller, it was about 80 plus patients, was trastuzumab plus gemcitabine cisplatin as a frontline setting for treatment-naive HER2-positive biliary tract cancers, and the combination of the trastuzumab with gemcitabine cisplatin led to a median progression-free survival of 7.95 months and a median overall survival of 9.95 months. So very interesting and very exciting ASCO for all of us who treat cholangiocarcinoma patients. And with that, I'm going to give it back to you, Alana, for questions.
Thank you. So let's start with the case 1 discussion. This is a patient, his name is Joseph. He's a 60-year-old man. He's recently been diagnosed with multifocal intrahepatic cholangiocarcinoma. He has bilobar hepatic disease and metastasis to the lungs. However, his ECOG performance status is 1. He's been initiated on gemcitabine, cisplatin, and durvalumab, and subsequently progresses. Let me ask you this question. Shubham, what is your next step in management?
Yeah, in golf, we call it a chip shot. So thank you for that. Thank you for that question. So one thing I wanted to actually tell the viewers is, which was of interest that we didn't show, that is part of the presentation, is about 26% of the patients, so 1/4 of the patients did get some kind of checkpoint inhibitor before they got Zanidatamab. So that's an important thing because now it's widely, accepted. When we did the trial, this was the checkpoint inhibitors were not approved. So 1/4 of the patients did get Zanidatamab. We did a post hoc analysis on these 1/4 of these patients, and the response was exactly the same. It was like at 41 or 42%. So interestingly, it really did not change in this post hoc analysis. Again, a subset analysis, small number of patients, but we did do that post hoc analysis because the reality is these are approved now agents. Mm-hmm. But to come back to your question, the next step in management, per the NCCN guidelines, we can always do trastuzumab pertuzumab. That's part of the NCCN guidelines if we can get it approved. as part of a clinical trial, I would, would love to enroll them into Zanidatamab, but that trial is closed now. But if you had a trial open, that's what I would go for, or any HER2 basket trial, which is available of maybe an ADC, that would also be reasonable, looking at all the, looking at all what we see come out from ASCO 2023. So I think the future is bright. So I've got, different ways to treat these patients now.
So let me ask you this question. When would you consider, what would you consider is the optimal time for doing molecular profiling or NGS testing? Because perhaps for not all patients would this information be available?
Yes, I would. Yeah. So great question, Alana. And the main thing is, if you don't look, you will not find, right? So we need to look to find. And next-gen sequencing, I would recommend anybody with locally advanced or a metastatic BTC, and anybody in that should get next-gen sequencing, because not only HER2, you can find the TMB, you can find MSI, you can find BRAF mutation, V600E, that's targetable in BTC also. You can find FGFR, NTRK fusions, and HER2 amplification. So it's a target-rich disease. We need to do it in all our patients who are advanced.
So as sort of the title of the slide says, we found that the NGS testing has revealed a HER2 amplification. You've already mentioned that if a trial was available, you would consider Zanidatamab. And how would you approach the patient counseling for potential adverse events?
Yes, so potential adverse events is very, very important, both for all our ADCs and for Zanidatamab. So specifically for Zanidatamab, the main toxicity that I saw in my patients was diarrhea. So I would tell them to watch out for it, just like we do with FOLFIRINOX or TCAN that we give. We talk to our patients, we counsel them, we tell them to have Imodium on hand or loperamide on hand, hydrate themselves. If they're starting diarrhea, they should start taking Imodium, and they should contact us. If the diarrhea gets is increasing in frequency in spite of taking Imodium, it doesn't get better, then they need to contact us early so we can get them hydrated if they need IV hydration. So it's all about patient education, which is very important. And we really, these patients did well. As far as infusion-related reactions, as I said, majority of the patients did get pre-medication with the standard. We had a steroid, we had I think paracetamol or acetaminophen, depending on the geographic location. And then we had either diphenhydramine or another kind of similar agent, antihistamine, depending on the geographic location. We really did not see a lot of it. And really after the first couple of cycles, it really dissipated. So for the patients though, it's more about education and really having Imodium at hand.
So our next presenter is Dr. Jeffrey Koo. He's an associate attending and head of the Esophagogastric section. He is a part of the Gastrointestinal Oncology Service, member of Cellular Therapy Service, Department of Medicine, Memorial Sloan Kettering Cancer Center in New York. Welcome, Dr. Koo.
Dr. Lamova, thank you so much. It's really a pleasure to be with the both of you tonight. So I believe that we'll also start off my section with a question and that you will also pose to me.
So Thomas has recently been diagnosed with stage 4 G-junction adenocarcinoma, which is metastatic to lungs. His ECOG performance status is 0. You order HER2 testing on the biopsy with your pathologist colleague. Your pathologist colleague uses IHC for HER2 testing and reports back that the score was 2+. So what is your next step?
There is a hierarchical reflexive testing for HER2 in esophagogastric cancer that's pretty established, but certainly an IHC result of 2+, as you know, is indeterminate. So almost automatically, a pathologist should then defer or kind of refer for FISH testing. So let me then talk about the current treatment algorithm. And this is an algorithm that's accepted around the world, but certainly in the US is endorsed by CAP, so the College of American Pathologists, as well as ASCO. And again, the hierarchical nature means that we start with immunohistochemistry, the benefit of which is that it's a quick test with a short turnaround. And if you have a result that's 0 to 1+, that is a HER2 negative tumor and no additional testing is needed. On the other hand, if you have an IHC3 plus tumor, that's also considered a positive HER2 positive tumor, and also similarly, no additional testing is required. The only situation where additional testing is required is exactly as in the case discussion. If you have an IHC2 plus result, that's considered indeterminate. One should then perform FISH. Again, FISH is more costly, potentially takes up to a calendar week to result. But if the FISH result is negative, that's considered HER2 negative. If the FISH is positive, then that's considered HER2 positive. And you see that leads to very different treatment options. Certainly focusing on the right, if we focus on HER2 positive disease, the standard of care globally and in the US until recently would be chemotherapy with a platinum fluoropyrimidine doublet in addition to trastuzumab. So an additional point about HER2 testing in esophagogastric cancer versus something like breast cancer is that it's quite different. So first of all, there is significant heterogeneity between one tumor cell and the next. And likely because of this, there is certainly a higher possibility of having a false negative result. So as a result, it's actually very important to try to obtain as much of a tumor biopsy as you can, and also to analyze as much tissue as you can. So this really goes back to a gastroenterologist or to an interventional radiologist who's doing the initial biopsy. It's always important in gastric cancer to try to get as much tissue as possible. Now, one other unique feature about HER2 staining is that the protein expression actually is absent on the digestive luminal membrane, meaning that the staining is not completely circumferential, and this is the so-called basolateral pattern. So ultimately, because of all these reasons, it's really important that specific criteria for esophagogastric cancer be used for HER2 testing. But more importantly, it's important that the HER2 testing be done in a reference lab, and in a central lab, or in a lab that has experience in testing HER2 tumors in gastric cancer. So another important question is who should be tested for HER2 overexpression, and when should this take place? And here we see guidelines from various international societies from Asia, Europe, as well as here in the US. The answer is pretty straightforward. Essentially, any patient with metastatic disease should be tested for HER2 positivity. Now, the NCCN guidelines on the right have an additional caveat or situation. At the time of progression on HER2-based therapy, they also recommend repeat biomarker testing, ideally of a progressive lesion. And the reason for this is that there are now multiple data sets that show that up to about 30% of the time, an initially HER2 positive tumor can become HER2 negative at the time of progression on HER2-based therapy. And we think that this is likely an acquired mechanism of resistance to the initial HER2 treatment. Now, I'll come back to this when we talk about the studies involving TDXD or trastuzumab deruxtecan. So, as we talked about, with regards to Thomas, we would then perform FISH testing, and in this case, FISH is positive, which means IHC2 plus, FISH positive. He therefore has a HER2 positive tumor, and therefore that we can then talk about therapeutics for our patient Thomas. Now, I already alluded to this, but I think all of us on this call are aware of the TOGA study. This was a pivotal study that was published in 2010. This is the first study to show benefit for adding an anti-HER2 therapy or any targeted therapy to esophagogastric in the first-line setting. It actually was the first study where the median overall survival in the experimental arm crossed the psychological 1-year barrier. Again, randomized phase 3 study, nearly 600 patients were randomized to receive a fluoropyrimidine platinum doublet with or without trastuzumab. Response rate and progression-free survival were improved in the experimental arm, and of course, there was also a significant improvement in overall survival in the experimental arm, and you see that represented here. Median overall survival is 13.8 months versus 11.1 months in patients who received chemotherapy alone. Now, this is actually a critical point and actually ties back to why we test for HER2 the way that we test for. So back in the day, the definition of HER2 positivity was IHC3 plus or FISH positivity. So on the top in the forest plot, you'll see the various subgroup analyses. But what I've highlighted is a post hoc exploratory analysis in which outcomes were stratified based on patients who are what we would now call HER2 positive in a contemporary setting. So in other words, IHC3 plus or IHC2 plus FISH positive versus a smaller group of patients who were IHC0 or 1 plus and FISH positive. And you'll see that all of the benefit seems to have accrued to what we now consider HER2 positive patients, and the other patients did not seem to derive benefit, hazard ratio close to 1 with very wide confidence intervals. So at the time, the regulatory agencies around the world handled these data in different ways. Here in the US, actually, trastuzumab in combination with chemotherapy was actually approved based on the intention to treat patient eligibility criteria. But in Europe, the EMA actually approved it based on the patients who are most likely to benefit. We know now in the fullness of time that here in the US and around the world, we now consider HER2 positivity to be exactly what I've discussed, IHC 3+ or IHC 2+ and FISH positive. So at the time that TOGA was conducted and presented, there really was a hope that that would be the first of many positive HER2 studies in esophagogastric cancer, and that essentially we would inherit and test the hand-me-downs for breast cancer. But unfortunately, that really was not the case. For nearly the next decade, we had a series of negative randomized phase 3 as well as randomized phase 2 studies, and I present them here for your information. In fact, the one study that was technically negative, but that came the closest to being positive was actually the Jacob study. And this was a study that added pertuzumab to the standard combination of trastuzumab and chemotherapy. There actually was statistically significant improvements in both response rate as well as progression-free survival. And you'll see that overall survival actually was numerically improved. There was about a 3-month improvement. Hazard ratio was 0.84, but the study just missed statistical significance. P-value was 0.057. So the assumption is that if the study had been larger, it probably would have been powered to detect a survival difference. But nevertheless, I mean, there are no longer any evaluations of pertuzumab in gastric cancer. But again, I think this is relevant, and I mentioned this because trastuzumab, pertuzumab, in one molecule is Zanidatamab, and I'll talk about the Zanidatamab data in the next couple of slides. So I think all of us are also familiar with Keynote 811. This really was a successor to the TOGA study, in which pembrolizumab was added to the combination of trastuzumab and chemotherapy. This again was a large phase 3 study, enrolled nearly 700 patients. Primary endpoint are survival outcomes, but an important secondary endpoint was response rate. So these are the results of a planned interim analysis. So this is not the entire population. This is merely the efficacy population of about 260 patients. And in this planned interim analysis, there was a dramatically, significantly improvement in response rates to almost 75% from 52%. P-value was highly statistically significant. You'll see that in the pembrolizumab arm, there was an 11% complete response rate. What's interesting is that duration of response was not significantly improved in the pembrolizumab arm versus the regular trastuzumab plus chemotherapy arm. But nevertheless, on the basis of this improvement in response rates, without survival data remained pending at this time, this combination actually was approved by the US FDA, so that in the US now, pembrolizumab plus trastuzumab and chemotherapy is standard of care. Now, this is in contrast to everywhere else in the world, where trastuzumab plus chemotherapy remains standard, pending the survival data that are eagerly awaited. So this actually has created an unusual situation where the clinical environment is different in the US and the rest of the world. And this actually does have impacts on clinical trial accrual, which I'll talk about briefly as well in the next several slides. Now, T-DXd is something that Dr. Panta has already talked about, and we've heard a little bit about this molecule. So it is an antibody drug conjugate, and there are potential advantages that I've highlighted on the left. First of all, the topoisomerase inhibitor, the deruxtecan, is very high potency. There's a high ratio of trastuzumab to payload molecules is about 1:8. And actually, most significantly, there is the potential for what's called a bystander effect. You'll see in the cartoon on the right that trastuzumab is linked to the deruxtecan with a cleavable linker. Once this molecule is internalized into a tumor cell, it actually is cleaved, and the deruxtecan can actually then diffuse into other neighboring cancer cells. And this may be particularly advantageous in gastric cancer, where, as I mentioned, HER2 positivity tends to be a little bit spotty or patchy or heterogeneous. So in other words, it can diffuse from a HER2 positive cancer cell theoretically into a HER2 negative neighboring cancer cell. So T-DXd was evaluated originally in the Destiny Gastric 01 study. This is a study that was performed exclusively in East Asian patients, mostly from Japan and Korea. It was a randomized phase 2 study that looked at T-DXd versus dealer's choice of chemotherapy, and that was either irinotecan or paclitaxel, as third-line therapy for patients with HER2 positive disease. primary endpoint of the study actually was response rate, and that was and that was significantly improved. You'll see at the bottom, response rate was 51% versus 14%. But if the primary endpoint was met, an important secondary endpoint analysis was overall survival, which you see represented in the Kaplan-Meier curve on the left. And you'll see dramatic improvement in median overall survival of nearly 4 months, has a ratio of 0.6, highly significant, and also statistically significant. So building on this, the next study that followed was DESTINY-Gastric 02. So this was a single-arm phase 2 study that was conducted in patients in the US, North America, as well as Western Europe, with HER2-positive disease. And again, unlike DESTINY-Gastric 01, which was a third-line study, this was a second-line study. Now, a very important difference as well is that in this study, patients have to have a mandatory pre-treatment biopsy after progression on trastuzumab, because as I already mentioned, up to 30% of the time, HER2 positivity can be lost. Primary endpoint of the study was confirmed response rate, and you'll see the outcomes on the right. Confirmed response rate was 41.8%. And then we now also have survival data. Median PFS is 5.6 months. Median overall survival is 12.1 months. And we see that represented here in the Kaplan-Meier curves. These results actually are virtually superimposable upon the results from DESTINY-Gastric 01. Now, on the basis of both DESTINY-Gastric 01 and Gastric 02, T-DXd is now approved in many places around the world. The first place it was approved in was in Japan in September 2020. That was based on the DESTINY-Gastric 01 data and consistent with the patient population. In Japan, it's approved as third-line or greater treatment. Interestingly, T-DXd was approved several months later, January 2021, in the US. It actually was approved also on the basis of DESTINY-Gastric 01 data, but in the US, it's approved as post-trastuzumab therapy, meaning that patients can receive it in second line. And then most recently in Europe, it was approved in December 2022 on the basis of both of these studies. And in Europe, like in the US, it is also approved as second line or greater therapy. There are other ongoing DESTINY-Gastric studies. The one I'll mention is DESTINY-Gastric 04. This is actually a phase 3 study that's looking at second-line T-DXd versus standard of care ramucirumab paclitaxel. So one thing definitely to talk about is interstitial lung disease, which that's associated with T-DXd. So Dr. Pant, I was actually surprised in the study that he mentioned that it was about a 25% rate. But in most other larger studies in various solid tumors, we do see an ILD rate of 10% in all patients. Unfortunately, that does include grade 5 toxicity in some patients, meaning that it causes death. So with this slide, I'll refer you to the third column, which is how we manage it. So first of all, what is grade 1 interstitial lung disease? Grade 1 interstitial lung disease actually means that a patient is completely asymptomatic, but we see radiographic findings, ground glass opacities, and imaging that ultimately are consistent with ILD toxicity. Even for patients who have no symptoms but who have radiographic evidence, the current guidelines are to hold treatment completely until the CT findings completely resolve. One can consider giving low-dose steroids under these circumstances. Now, if the interstitial lung disease does not resolve within 7 weeks, T-DXd actually should be permanently discontinued. On the other hand, with any higher grade, grades 2 to 4 ILD, T-DXd has to be permanently discontinued, and patients have to be started on steroids right away. Clearly, I would advocate and recommend for having an experienced pulmonologist be involved in management of any of these toxicities. So Zanidatamab, we heard a lot about it. This is from the basket study, and there was significant activity in the patients with gastric cancer who were treated. So this led to a phase 2 study. This is the ZW25-201 study. This was an open-label study evaluating 3 different combinations of Zanidatamab with CAPOX chemotherapy, with 5-FU cisplatin, and with FOLFOX chemotherapy. First part of the study was to establish safety, and if each regimen was safe, then the next part was to look at response rate as well as survival outcomes. These are the toxicity data. This is a very busy slide, but I would point out that the one toxicity that emerged was diarrhea. So to, I think, the great surprise of investigators and patients on the study, there was a grade 3-4 diarrhea rate of 40% with a combination of Zanidatamab and chemotherapy. We've already heard that Zanidatamab does is associated with diarrhea on its own, but this toxicity is really significantly increased when combined with chemotherapy. So based on these early data, the study was modified so that all patients received mandatory loperamide prophylaxis, and with that, the grade 3-4 diarrhea rate came down to a slightly more manageable 20%. So these are the efficacy data. If you focus at the column on the right, in 28% in 28 patients who were response evaluable, there was a confirmed objective response rate of 75%. The disease control rate was 89%, and the median duration of response was very encouraging at 16 plus months. More recently at GI ASCO, Dr. Alamova updated these data to include survival data. You see that the median PFS is 12.5 months, which is encouraging. But what's even more impressive is the overall survival. Median overall survival actually is not reached, but the 18-month overall survival rate is a very impressive 84%. So based on these data, the Horizon GEA-01, which is a phase 3 study, is currently ongoing. So this study actually has 3 arms. The standard arm is trastuzumab plus chemotherapy, and there actually are 2 experimental arms. One experimental arm is Zanidatamab plus chemotherapy alone, and the second experimental arm is Zanidatamab plus immunotherapy. Tislelizumab is an anti-PD-1 antibody plus chemotherapy. Primary endpoints are survival outcomes, and the study is powered to compare both experimental arms to the control arm. Both experimental arms are not meant to be combined, compared to each other. So because KEYNOTE-811, pembrolizumab plus trastuzumab and chemotherapy is standard in the US, the study actually is not open in the US because the control arm does not include immunotherapy. So there are other novel anti-HER2 therapies that I've listed here, but for the interest of time, I will not go into them, but they are provided as a reference. So in summary, we all know that the TOGA study established that trastuzumab plus chemotherapy is a standard of care in the first-line setting. More recently in the US, the addition of pembrolizumab was based on the KEYNOTE-811 data with survival data pending at this time. TDXD, trastuzumab, deruxtecan, can provide benefit in the second-line or later setting. It is important to monitor for interstitial lung disease, and that is equal part physician as well as patient education. There are other ongoing studies of TDXD. And finally, the phase 3 Horizon GEA-01 study is currently evaluating Zanidatamab in the first-line setting for HER2-positive disease. So with that, we will finish with another case discussion, and I'll invite Dr. Alamova to present that.
So we have a 70-year-old male presenting with worsening dysphagia, reflux symptoms, and 20 pounds of weight loss over 6 weeks. Sounds like our typical patient. EGD reveals a G-junction tumor. Biopsy is positive for invasive adenocarcinoma, which is moderately differentiated. HER2 is IHC 3+, and PD-L1 CPS is 10. It's mismatch repair proficient. You have a subsequent M.Sc impact testing revealing an HER2 amplification, 5 mutations and 4 copy number alterations. None are actionable. TMB is 4.4, and a CT chest of the abdomen, pelvis, and chest reveals G-junction thickening, periesophageal lymph nodes up to 2 centimeters, and several liver lesions up to 3 to 4 centimeters, all of which are consistent with metastatic disease. So let me ask you this question. What would be your next step in management, and what would you recommend for systemic therapy?
Yeah, so I mean, I think that at this point, I think would have enough information to initiate treatment. I think one question would be, whether one would biopsy the liver lesions to document that they represent metastatic disease. I personally would not. I mean, 50% of patients in North America present with metastatic disease. The liver is an extremely common site of presentation. My typical practice is to consider a biopsy of a suspected metastatic site only if there's a very atypical or kind of discordant response. So certainly on the basis of this, I would accept that the patient does have HER2-positive metastatic disease. So, as discussed, outside of a clinical study here in the US, we would offer that patient pembrolizumab, trastuzumab, and chemotherapy, and almost always I would offer patients FOLFOX chemotherapy, especially in this case when the patient has dysphagia, may not be able to swallow something like capecitabine. We've of course all talked about the phase 3 study with Zanidatamab. And again, I mean, you and I talked a little bit about this before the start of this. It really is a pity that unfortunately that study is not accruing in the US because the control arm does not include immunotherapy, which is now standard of care. But certainly that or another HER2 positive study would certainly be a strong treatment option as well.
Thank you. So this patient initiated treatment with pembrolizumab, trastuzumab, and FOLFOX. Dysphagia resolved after 2 cycles. A CT scan after 4 cycles reveals significant disease in the esophagus, the periesophageal lymphadenopathy, significant decrease in the esophageal thickening, periesophageal lymphadenopathy, and liver metastasis. But oxaliplatin has to be discontinued after 8 cycles because of development of intermittent grade 1 neuropathy in his hands and feet. He then continues with pembro, trastuzumab, and 5-FU for another 8 months before he experiences progression of 1 and only 1 of his liver metastases. There was also some increased thickening in the distal esophagus, and he also had worsening dysphagia for solid foods. So what would you do next now?
Yeah, so I like your emphasis on the fact that only 1 of the liver metastases progress. I mean, I think outside of a study, I think if there's small volume of progression, but the patient remains well, certainly I think one option would be to continue the current treatment. I mean, we don't have limitless options, so I think being a little bit conservative about when you change treatment makes sense. But I think in this case, what really prompted me to consider changing treatment was that for the first time, and he began to have recurrent dysphagia, which had resolved right away with treatment. So on that basis, I thought that we did have to change treatment, and consistent with what I've talked about, we as an institution try to biopsy progressive lesions to try and document whether the tumors remain HER2 positive or not. So in this case, the option would be an IR-guided liver biopsy, or because he was having more dysphagia, an endoscopy to biopsy the primary tumor. And for us, it's always a little bit quicker to get an endoscopic biopsy. So that's exactly what we did. And in fact, it did turn out that the primary tumor remained HER2 positive. IHC was exactly 3+.
So this is a little bit unusual given progression, but in this setting, what systemic therapy would you recommend next? Would you recommend TDXD? Would you recommend paclitaxel ramucirumab? If a trial of Zanidatamab were available, would you consider that?
Yeah, so certainly I think I think that while there technically is equipoise between ramucirumab, paclitaxel, and TDXD, and again there is an ongoing global study that's not enrolling in the US and not enrolling in Japan, I mean, I would favor TDXD in this context, given the high response rate as well as favorable duration of response. Similarly, I think there is equipoise between Zanidatamab and TDXD to focus on HER2 therapies in particular. I think the single agent activity of Zanidatamab based on the basket phase 1 study and actually a pretty kind of treatment refractory setting was encouraging and was somewhat in the ballpark of TDXD. So certainly, I think if there were an experimental option or experimental study involving TDXD, I think it certainly would be a strong consideration and something to discuss with the patient as well.
Thank you. So now we'd like to move into the audience question and answer portion of the program. And there are a few questions that have come in. So I'll start with the first one. And maybe I'll pose this question to Shubham first and then to Jeff. Is there any role for HER2 targeted therapy in the neoadjuvant setting for BTC?
That's a great question, Anna. So in BTC, again, like I said, it's a heterogeneous disease, right? So you have gallbladder cancer, which is about 20 to 30%, extrahepatic cholangio, which is about 10 to 20%, and intrahepatic cholangio, where you really see that locally advanced, is about 1 to 5%. So it's kind of a small number. So if we did introduce in the neoadjuvant setting, I'm sure we would see responses because we did see a pretty robust response in these patients. But it would be very challenging to the trial to show that same because of the patient population is limited. So I think would be great. I think it's a valid target. It's an oncogenic driver. We are going to see responses. So out of a clinical trial, patients, they can be consideration locally advanced cancers to to add on at least some HER2 targeted agent because we know it shows benefit, and we have that GEMSIS data in frontline now with trastuzumab. So there is some data out there that can be used to try to maybe downstage these tumors in the neoadjuvant setting.
Thank you. Jeff, the same question to you. Do you think there is a role for HER2 targeted agents in HER2 positive gastroesophageal adenocarcinoma?
Yeah, well, I think there's definitely a role, but I think that, the completed studies have been mixed. So I think the study that some people may be aware of is the RTOG-1010 study, which is performed, here in the US. It was a study that added trastuzumab to actually chemoradiation with carboplatin and paclitaxel for esophageal and GE junction adenocarcinomas that were HER2 positive. And the results were presented, about 2 years ago, and to everyone's surprise, flatly negative. No improvement in pathological survival outcomes with adding trastuzumab to chemoradiation. On the other hand, we definitely have a signal of activity in a study performed by the German group called Petrarca, and that's where they added trastuzumab and pertuzumab to perioperative FLOT chemotherapy. So it was meant to be a randomized phase 2 study that, if positive, would lead to randomized phase 3. The randomized phase 2 part, the primary endpoint of the randomized phase 2 part was pathologic complete response rate, and that actually was significantly increased with adding pertuzumab and trastuzumab. The path-CR rate, I think, was about 35% versus more like 15% with FLOT chemotherapy alone. So quite a significant difference. Two problems there. One was there actually was a grade 3-4 diarrhea rate also of about 40%. And then, as I mentioned, when the JACOB study with the phase 3 first-line metastatic study, when that read as being negative, pertuzumab was no longer evaluated, and so the phase 3 study never happened. But certainly that would suggest that there is the potential for activity for anti-HER2 therapy. And I know now the cooperative groups and others are trying to kind of come up with a strategy looking at anti-HER2 therapy in the perioperative setting. But it's it's surprising. TOGA was in 2010. 13 years later, we actually don't have a validated anti-HER2 strategy in the locally advanced setting.
Thank you. I think the next question also for both of you, and maybe Shubham, you could start again. When should you use anti-HER2 agents with and without other targeted agents?
Yeah, so normally, what a lot of the data, at least in BTC, is in the second line and post-second line setting. So I'm a big believer if it's an oncogenic driver, it works, you should move it a little bit earlier. So not wait for the third line setting, give it in the second line setting. So normally what I do in my practice is all the BTCs which come to my practice, if they're locally advanced metastatic, I sequence them. And then based on, and then they get chemo frontline with immunotherapy nowadays. And so I have that information ready to go for, if they're progressing. So I would include it early, earlier, not wait for the third line setting, kind of would do it in the second line setting. As far as combinations, there's definitely data for trastuzumab, pertuzumab, again, a combination. There's a clinical trial data for Zanidatamab, though it's not approved in this setting. There's also, for tucatinib and trastuzumab, there's data, again, not approved in that setting. So, but there's combination data that I can potentially use for my second line patient, for my second line HER2 amplified patients. And I have a couple of patients on trastuzumab, pertuzumab who are doing well.
Jeff, the same question to you.
Yeah, so I guess, again, I think in terms of not quite a targeted therapy, but again, in the US, pembrolizumab plus trastuzumab and chemotherapy, is approved in the first line setting. Since all of these treatments have moved in the first line, later line HER2 strategies, other than TDXD as monotherapy, are still evolving. But one of the Destiny studies, Destiny Gastric 03, is actually kind of a phase 1b/2 study. It's signal finding, looking at multiple different kind of cohorts in the second line and first line. I believe that there is a second line cohort looking at ramucirumab, anti-androgenic therapy in combination with TDXD, because there are preclinical data suggesting that anti-androgenic and anti-HER2 therapy can potentially have additive or synergistic benefits. So there are combinations like that are being looked at.
Just one quick question that just came through. For off-label use of small molecule TKIs or other agents, can we treat HER2 genetic mutations rather than HER2 amplifications, so positivity based on amplifications with these drugs? And the question to both of you, because we did show that mutations are present in small number of these patients as well.
Yeah, I could go first. So in BTC, there have been trials, really haven't had high response rates. So I would, be challenging in the BTC space.
Yeah, and I mean, Elena, please feel free to add. But I think that again, HER2 mutations actually are extremely rare in gastric. I'm not aware of any data showing activity one way or the other. But also, I mean, there are a number of the TKIs. For example, lapatinib was evaluated in 2 phase 3 studies and was negative in gastric cancer. There is a study, the Mountaineer study, that's looking at tucatinib plus trastuzumab plus chemotherapy in the second-line setting. That study has completed accrual. But really, with regards to HER2 mutations, it's very rare, and I'm not aware of data one way or the other.
Yeah, I agree with you, Jeff, 100%. So thank you very much for this very good discussion. And this will conclude our program tonight. Thank you very much for your attention.
Thank you, Lena. Thank you.
Thank you.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/NXP860. This program is supported by an independent medical education grant from Jazz Pharmaceuticals.